Hi, I think we're going to get started here. Just want to make sure that we're going to give people a minute to get to join us and make sure that people can hear and all of our technology is working. I think there's an option to chat, so if you're having any trouble, chat and Kelsey will help us troubleshoot. I'm Chloe Zara. I am the Director of Network Obstetrics Population Health for the Beth Israel Deaconess Medical Center Department of OBGYN. And I'm going to talk about gestational diabetes today. So welcome, feel free to fire questions and I'll try to field them if we can figure out this technology. It's very disorienting for those of you who give talks periodically to be talking to a screen. So please feel free to fire questions away. That will make me feel a little more comfortable. So the objectives of my talk today, I want us to talk a little bit about trade-offs and controversies for the current screening guidelines surrounding gestational diabetes diagnosis. I'm going to talk about treatment and obstetric management pearls and strategies and help get you thinking about best practices for prevention of type 2 diabetes after pregnancy is complicated by gestational diabetes. First, we'll talk a little bit about screening guidelines. So the definition of gestational diabetes has remained very vague. It changes slightly from year to year, but in this year's Standards of Medical Care in Diabetes, published by the American Diabetes Association, GDM is defined as diabetes diagnosed in the second or third trimester of pregnancy that was not clearly overt diabetes prior to gestation. Now, what that actually means in practice is much more controversial. The WHO in 2006 endorsed the use of a 75-gram oral glucose tolerance test. Definitions in the table, as you can see, with fasting greater than 126 or a 2-hour greater than 200 milligrams per deciliter. They also define impaired fasting glucose as a fasting of 110 to 140 and impaired glucose tolerance as a 2-hour value of 140 to 200. Both impaired fasting glucose and impaired glucose tolerance can be considered gestational diabetes if this diagnostic testing is utilized during pregnancy. And obviously, those very high fasting and 2-hour values count as kind of overt diabetes in pregnancy. The International Association of Diabetes and Pregnancy Study Groups, or the IADPSG, published guidelines in 2010, which represented kind of a major update, and we'll talk a little bit about that history in a second. Also using a 75-gram oral glucose tolerance test. With these thresholds in the table next to it, you can see a fasting of greater than 92, a 1-hour value of greater than 180, or a 2-hour value of greater than 153. Interestingly, those values are not that easy to remember, and there was some debate at the time about rounding up or down to make them a little bit more clearly identifiable. And it turns out you really affect the prevalence of gestational diabetes if you change those thresholds even slightly. Again, something we're going to talk about in a second. That testing strategy has become known as the one-step testing method, in which a 2-hour test is given and any one abnormal value on that test is considered gestational diabetes. The American College of OBGYN as recently as 2018 has re-endorsed the use of a 2-step testing paradigm, or what most people in the United States use, which is a 50-gram glucose load test for screening purposes, followed by a 100-gram oral glucose tolerance test for diagnostic purposes in folks with an abnormal screen. So the thresholds that are used, again, are very controversial. There's no gold standard, and ACOG endorses the use of a value of 130, 135, or 140 as abnormal for the 50-gram test, and prefers the use of the Carpenter-Coustan criteria, but also would accept the NDDG criteria, which I have listed here. Suffice it to say, there's a lot of numbers to remember, and I think most people still look these up or use their reference lab values to identify them. There are subtleties to the different differences in the proportion of the population that's diagnosed as positive, depending on the thresholds you use. But most folks in the United States have at this point adopted the Carpenter-Coustan criteria if they're going to use a 2-step testing paradigm, which is a fasting of greater than 95, a 1-hour of greater than 180, 2-hour of 155, or a 3-hour value of 140. Now note that unlike the one-step testing paradigm in which one abnormal value buys you the diagnosis of gestational diabetes, in a two-step paradigm, not only do you need two different tests, but you also need two abnormal values on the diagnostic testing to officially qualify as gestational diabetes. In the most recent practice bulletin that ACOG published again in 2018, they do have a note that one abnormal value has been associated with adverse obstetric outcomes. I think most of us know one abnormal value is associated with bigger babies. And so there is some discussion about whether or not we should consider folks with one abnormal value on a 3-hour glucose tolerance test to warrant treatment of some kind. However, for the moment, that is still not officially considered gestational diabetes. And finally, again, the ADA publishes standards in medical care for diabetes, including diagnostic and treatment standards every year. And in this year's most recent update, they say one-step or two-step methods are fine. If you're going to use the one-step method, the IAD-PSG thresholds are recommended. If you're going to use the two-step method, the Carpenter-Coustan thresholds are recommended. So how did we get here? It's this confusing table with lots of different values and lots of different testing paradigms. So gestational diabetes was originally defined by the risk for long-term adverse maternal outcomes, actually by a group out of Boston. There was a recognition that adverse fetal outcomes were also associated with glucose intolerance, but it's really been unclear until the last decade or so what the glucose thresholds were where this became clinically relevant. There's also a lack of level 1 evidence or randomized controlled trial evidence to support treatment at various thresholds. So there was a consensus that there was need for more data. There have been 2 large treatment trials of what's considered mild gestational diabetes. The ACHOICE trial, which was published in 2005 in the New England Journal, was in predominantly in Australia. And then the MFMU treatment trial, which is a randomized controlled trial conducted in the United States that was published in 2009. And both of them demonstrated that treatment of even mild gestational diabetes, or treatment in the case of people who did not have overt elevated fastings or significant elevation in their postprandial values, was associated with benefits. Specifically, folks who were treated had lower rates of pregnancy-induced hypertension and preeclampsia, lower rates of cesarean delivery despite having a diagnosis that's been associated with higher rates of C-section in some studies, significantly lower rates of macrosomia, non-statistically significant, but notably if you just look at the percentages here, lower rates of birth trauma, and then some subtle differences in the rates of jaundice. No change, interestingly, in the rates of hypoglycemia. The hyperglycemia and adverse pregnancy outcomes study was then another attempt at demonstrating whether or not there was some relationship between glucose, maternal glucose levels and outcomes that could help establish a diagnostic threshold for the diagnosis of gestational diabetes, or help bring us to some consensus. So this was a huge prospective cohort study that looked at the risks of hyperglycemia sort of less severe than what had qualified for treatment in other trials previously. They gave an enormous number of women a 75-gram oral glucose tolerance test at 24 to 32 weeks. And as long as they didn't have an elevated fasting or an overtly elevated 2-hour value, the clinicians were blinded to the results. And then they just mapped out what happened in that group of patients. And what they saw was that for every outcome they looked at, regardless of the time point at which the glucose value was drawn, there was essentially a linear relationship between maternal glucose category, which along the x-axis here you can see, for example, and this is looking at frequency of birth weight over the 90th percentile. And this is looking at the glucose category. So as the maternal glucose increased, both at fasting, at the 1-hour time point, and at the 2-hour time point, the likelihood of having a baby with a birth weight over the 90th percentile increased in a linear fashion. That relationship was similar for primary cesarean delivery, for rates of clinical hypoglycemia in the neonates, and for rates of elevated cord blood serum C-peptide, which is a marker for how much insulin the fetus is producing. So all of this is to say, well, I should also say that the secondary outcomes were also statistically significantly associated with maternal glycemic category, and that included preterm delivery, shoulder dystocias and birth traumas, rates of NICU admission, rates of hyperbilirubinemia, and rates of preeclampsia. So what this really implies is that there's a continuous relationship between maternal glucose tolerance and the outcomes of the pregnancy, even if it's not overt diabetes. So even below the thresholds that most of us would say, for sure, this person needs treatment, there are definitely relationships between mom's glucose category and what happens with the baby, as well as what happens predominantly with her blood pressures. So the IAD-PSG kind of calculated glucose thresholds at which the odds ratios for specific outcomes in those adjusted models approached 1.75. And that's how they came up with those kind of wacky numbers of 92, 180, and 153, because that's where those odds ratios equaled 1.75. What the IAD-PSG had hoped to see was a J-shaped curve where they could say, okay, here's where we should draw the line, because, you know, if there were a J-shaped curve, you could say this doesn't matter, but for sure above this level does. But as I said, unfortunately, there's just a linear relationship. So much like controversies around diagnosis of hypertension, like when does blood pressure matter, basically the higher it is, the worse it is. And so you sort of have to pick a line in the sand. And what we've been left with is this controversy over what is really the line in the sand where it matters. So just to summarize, there are advantages and disadvantages to both screening strategies. For two-step screening, the advantages, you don't need to be fasting, so you can give a glucose tolerance test in a non-fasting state, as most of us know in our office. There's also level 1 evidence supporting treatment of gestational diabetes if you use Carpenter-Kusan criteria, as that was the criteria that were used for entry into the MFMU network trial of treatment of gestational diabetes. The disadvantages are that this testing strategy is cumbersome. Again, as most of us know from our own clinical practices, it's hard to get people back for a second test. The 100-gram oral glucose tolerance test is also a test that only really has thresholds established inside of pregnancy. So it's hard to extrapolate those values to anything clinically meaningful outside of pregnancy. And those thresholds were arbitrarily set really based on the likelihood of progression of moms to having type 2 diabetes, not on any clinically relevant outcomes during pregnancy. So one could argue that because they're not outcomes-based thresholds, we shouldn't be using them at all. In terms of one-step screening, the advantages, it's a simplified protocol for the patient. You have to go in one time. Of course, many more people will have to go in fasting and stay for a prolonged test than the number of folks who would have needed to have a fasting test done with a two-step protocol, but it is simplified in terms of just coming up with a process. It also lines up with what diabetes screening protocols are, or gold standards are, for non-pregnant adults, because a 2-hour glucose tolerance test is considered the gold standard for diagnosis of not just diabetes, but impaired fasting and impaired glucose tolerance outside of pregnancy. And there's level 1 evidence for treatment at the WHO thresholds if you look at the Australian data. The disadvantages, as I've mentioned, it's a fasting test, which not everyone is able to do easily. The WHO criteria, if you use the older criteria, probably underdiagnoses women who are at risk for significant complications that could be decreased with good glycemic control. And the IAD-PSG criteria increase the number of women who meet the criteria for gestational diabetes. Nobody has done any trials to study treatment at the new IAD-PSG suggested thresholds. And so we don't know if there's any benefit to treating this additional group of patients, which in some populations is actually a very large number of women. We just want to point out here that regardless of how we define gestational diabetes, it is on the rise. There's been a 56% increase over a 10-year period from 2000 to 2010. I would imagine there's actually fairly limited prevalence data out there. I would imagine that we will see similar increases from 2010 to 2020 as the obesity epidemic manifests in increased rates of obstetric complications. The impact of the IAD-PSG criteria on a population level is that we would diagnose many more women than a two-step or ACOG endorsed strategy. So in the original HAPO study, compared to 4 to 7% of the population diagnosed with a two-step testing paradigm, nearly 18% of the women met criteria for gestational diabetes by the IAD-PSG thresholds. There was a lot of variation between the centers, so depending on the population that you looked at in Providence, Rhode Island, which is probably fairly close to our population here in Eastern Massachusetts, there was a 15.5% rate of gestational diabetes based on those thresholds. However, in Southern California, it was closer to 25%. And another group in Southern California, one of the Kaiser groups, found that nearly 30% of their population would have been diagnosed using the IAD-PSG guidelines. So the NIH convened a consensus conference in 2013. These guidelines were published in 2010. There was debate about it between ACOG and ADA in 2011, and then an NIH consensus conference was announced in 2012 and held in 2013. And what they concluded after days of expert review was that there wasn't sufficient evidence to adopt a one-step approach. Everyone is sort of on the same page that it would be good to have the same diagnostic criteria, but there are a lot of concerns about increasing the prevalence of gestational diabetes from a health services perspective. There's also not a whole lot of outcome data. So at some point, the thresholds may be reconsidered. I think one really important piece of information that was discussed a lot at the NIH Consensus Conference was how much is all of this going to cost? So one group did a decision analytic model looking to see, assuming that you increase the number or you improve outcomes in folks who are diagnosed with gestational diabetes, specifically that you lower the risk for preeclampsia, for shoulder dystocias, and for birth injuries, and that after delivery, you reduce the future risk of diabetes. For every 100,000 pregnancies screened, by either way, you prevent 85 cases of shoulder dystocia, 262 cases of preeclampsia, and nearly 700 cases of future diabetes for about $20,000 per QALY, so per quality adjusted life year that you gain. However, these recommendations really are cost effective only if that assumption that post-delivery care reduces diabetes incidence holds. So only if we do something about mom's risks for future type 2 diabetes does any of this really matter from a cost perspective. What we're left with are a fair number of controversies still. The ADA initially endorsed those thresholds and ACOG didn't. There was the consensus conference that says there's not enough data. And what the current state of affairs is in 2014, the US Preventative Services Task Force said, screen after 24 weeks, we think that's a good idea. So we're at least all on the same page that we should do some sort of screening in the early third trimester. ACOG, in its most recent practice bulletin, has said either method is fine, but the two-step method is really the preferred method based again on the concerns that were raised by the NIH Consensus Conference. Where the American Diabetes Association has endorsed either method, but really prefers the one-step method because of the likelihood based on international evidence that outcomes are probably better if you treat more people. So what I should close by saying in terms of screening controversies is what both groups say is institutions and sort of groups, healthcare facilities should choose a standard and stick to it. So they should choose one threshold. If you're going to use a two-step testing paradigm, for sure choose one threshold for your 50 gram, and then use preferably the Carpenter-Coustan criteria, but either use Carpenter-Coustan or NDDG. But pick a standard and go with it, and then see what happens in your population, and be willing to change as a group if that's indicated by what's happening in your population. So moving on to treatment and obstetric management strategies. I'm going to talk a little bit about what is the standard of care. So a patient gets diagnosed with gestational diabetes. The first thing we recommend is quote unquote lifestyle change. What does that really mean? Well, medical nutrition therapy is what is considered the gold standard of treatment for gestational diabetes, and the estimates are that as many as 90% of women with GDM, depending on your population, will be adequately controlled just with medical nutrition therapy. And what that really means is self-monitoring of blood glucose, nutrition counseling, and discussion of Institute of Medicine gestational weight gain goals. Physical activity is also recommended as part of treatment with a goal of 30 minutes daily. Which, if anyone knows anything about, if you know, most people in the US do not get 30 minutes of physical activity daily, but that is the goal for everyone, including for pregnant women and including pregnant women with gestational diabetes. Just want to review glycemic targets. What we're shooting for is a fasting of less than 95, and then either a 1 hour postprandial of less than 140 or a 2 hour postprandial of less than 120. Whether you choose a 1 hour or a 2 hour, I would argue choose one and go with it. I tend to have patients check at 1 hour for a couple of reasons. One is that there are old data suggesting that glycemic control is better when people use a 1 hour postprandials compared to 2 hour postprandials. The other is that functionally it's just easier to remember when people check their blood sugar an hour after eating than when they have to remember to check it 2 hours later. So I find that patients have a little bit better adherence when we check at 1 hour postprandial. Either way, check one, go with it so that you remember what your thresholds are for normal and abnormal. I did want to put up here just kind of what normal blood sugars are to say that these are really not particularly normal blood sugars. And normal fasting is data from 50 women near term with no gestational diabetes and no obesity. And what this group found was that normal fasting was not quite 60. A normal 1 hour postprandial was just over 100 and a 2 hour was 90. So at the treatment thresholds we've established, we are still tolerating a fair amount of hyperglycemia. It really is probably the upper limit of normal. The nutrition counseling piece, I really would strongly encourage everybody, what the ADA guidelines say is that nutrition counseling should be performed by a certified dietitian with expertise in caring for pregnant women. Functionally, sometimes that can be really challenging to get people to, so I wanted to talk a little bit about nutrition prescriptions and what my approach is. First, you need to know somebody's pre-pregnancy BMI. Maternal self-report of weight is actually fairly accurate, so if people don't know how tall they are, you can measure them. That's relatively easy to do in the office, and you can either use a first trimester weight or maternal self-report of pre-pregnancy weight to calculate a BMI. Then you should look at the Institute of Medicine gestational weight gain guidelines, and I have a slide a little bit later that reviews those, and just see where people are at. A very common pattern that is seen is that people have excessive gestational weight gain early in pregnancy, get diagnosed with gestational diabetes, and then stop gaining weight entirely, which is probably okay, but we don't really know what the optimal pattern of gestational weight gain is and if that's associated with any harm. I think as long as fetal growth is reasonable, that's a reasonable strategy, but just to keep an eye on gestational weight gain is something to remember. Nutritionists will do a rigorous assessment of what people are currently eating. So there are a couple of ways to do that in clinical practice. A 24-hour recall in which somebody just recites what they ate for the last 24 hours can be accurate. A 3-day food diary is preferable, but takes time, obviously. That information is what you would use to come up with an individualized dietary prescription. And I've distilled that down to practical counseling in 5 minutes or less. Again, in my clinical practice, things I've found have the highest impact in terms of improving blood sugars, limiting liquid calories. Dunkin's gotten a little better about labeling what goes into their various frozen drinks, but people certainly may not count coffee as something that has carbohydrates, but when you ask what goes into their coffee, sometimes it is a lot of milk and sugar, so important to ask about what people drink. I think a lot of folks still feel that juice is an important source of nutrients, and it really isn't most of the time. And all of those are sort of easy, quickly processed carbohydrates when, anything liquid. Limiting processed carbohydrates is kind of the mainstay of what I recommend. I used to say, take everything white on your plate and make it brown. will give a little more nuance to that and say that, the foods made with white flour and white sugar, or brown sugar, but processed flour and sugar, if you limit that, you limit 90% of the significant offenders of problems. All of this is getting at just eat real food. Most people are not making their own sourdough, so I think if somebody has a particularly high quality source of processed carbohydrates, fine, but those are pretty unusual. Make half your plate green, get enough veggies in. I talk a lot about lean protein sources, specifically that fish is a great source of omega-3 fatty acids, and that the fish advisories really only pertain to high mercury fishes. So for patients who like fish a lot, that's a good protein source. We just talk about limiting things with a lot of mercury, which you can go to the EPA website and download the latest data pretty easily. And then healthy fats. So fatty fish are good for you, as are a lot of other healthy fats, avocados, nuts, olive oil, all good things. And all of those, increasing the fat intake is a way to get the calories you need and feel more satiated without sort of increasing carbohydrate intake. All of that said, the official recommendations of the American Diabetes Association are that women should get the daily recommended intake. And the daily recommended intake of carbohydrates right now is 175 grams of carbs a day, which if you've ever done any sort of dietary, either counseling or dietary modification of your own, you may know 175 grams of carbs is kind of a lot. If most of that's coming from plant sources, great, but if it's predominantly coming from processed sources, that can actually result in a fairly high carb, not great diet. So I would just be cautious about that. That said, there's certainly no evidence that keto diets or any sort of extremely low carbohydrate diets are beneficial, and there is some concern based on animal data and based on old data about the effects of ketosis on developing brains, that it may be harmful. I think we're a long way from knowing exactly what the right diet is. So I fall back on eating real food has to be a good thing. So that's my practical counseling. This is one source of good dietary advice. This is from the Harvard School of Public Health, freely downloadable. They have patient-facing materials that can be really useful. But basically focus on dietary quality more than calories and counting grams of anything. These are the goals, again, for gestational weight gain. So for most of our patients who are going to fall into the just statistically overweight or obesity category, the guidelines are either 11 to 20 pounds for obesity, 15 to 25 for overweight. Many women will have already exceeded these limits by the time they get to you with a diagnosis of gestational diabetes, or by the time we diagnose diabetes early in the third trimester. However, if they haven't, it's certainly something for us to keep in mind. And if they have exceeded those guidelines, sort of seeing if that plateaus, if weight gain plateaus, can be a useful barometer of how effective your treatment is. I will say also just a note about gestational weight gain in women with obesity, which is to say that baby fluid placenta plasma volume is somewhere in the range of 10 to 15 pounds, depending on the patient. So if you gain within this range of 11 to 20 pounds, really all you're gaining is pregnancy tissue. I don't think it's reasonable to tell women that they have to metabolize and break down fat stores during pregnancy. So if we tell women to break even, which is certainly was a common piece of advice I heard during my training in early years, I think what we're telling people is you need to lose weight and grow a human at the same time. And I think that sets up unrealistic expectations. We also have fairly limited data that that's safe. So this is just fluid baby placenta, a little bit of extra blood volume. And if people stick within these guidelines, they'll end the pregnancy where they started. In terms of physical activity, it's always important to assess current levels of activity. People often report that I am active, and that may actually be true. The goal is 30 minutes of structured physical activity daily. Practically speaking, my initial prescription for folks who identify as sedentary is that a 10-minute walk after each meal is a great way to to get started, and also to bring their blood sugar down just a little bit. Physical activity, I'll just skip through this relatively quickly to say that physical activity is safe. This is a study that got women to do a peak treadmill test at 28 weeks gestation, and then did like biophysical profiles. They had a continuous heart rate tracing. They looked at Doppler studies, and they saw no change with exercise. There were a couple of folks who were in the extremely fit group that really had high output on their treadmill test, who did have some spontaneous decelerations, and their fetal heart rate changes resolved with resolution of the exercise. So it's pretty hard to get there, is what the conclusion of this study was. Regardless, I think we all think like moderate physical activity is certainly safe. Whether or not it's effective, I think, is another question entirely. So there are very limited data out there about how effective physical activity is to manage weight gain. There's certainly almost no data out there about how effective it is to control blood sugars. I would say that it's good for people's mental health, if nothing else. It certainly can't harm people, and so I do think it's important, again, as a carrot, getting folks, practically speaking, out and walking after they eat can help bring down their blood sugars and can be an effective way to get people interested in moving. But I don't know that it's really been shown to be the most efficacious way of controlling blood sugars. So what if all of this isn't enough? First line treatments per the American Diabetes Association, ACOG, is insulin. Last year, when that practice bulletin came out from ACOG saying that insulin should be the first line treatment, SMFM came out with a practice kind of guideline the following day, emphasizing that metformin could be considered an alternative first-line treatment. I think I can shed a little insight into that and say that SMFM, the group that came up with these guidelines, expressed concerns about equity, and specifically inequitable access to treatment given insulin costs versus metformin costs. In some states, metformin is subsidized or very inexpensive, whereas insulin costs are a huge topic of conversation, and as many people know, people are rationing their insulin all over the place. Out-of-pocket costs for insulin are very high, and so if the alternative is no treatment at all, a treatment with metformin could be considered, and per SMFM can be considered a first line. In terms of insulin, if you're starting insulin, you can walk through this math. The total replacement dose is purportedly 0.7 to 1.0 units per kilo per day in the third trimester. If you do the math, let's say you have a 100 kilo patient, you do 1 unit per kilo per day, that's 100 units. You split that into half basal and half prandial insulin, so 50 units of her insulin should be delivered as basal over 24 hours. Split it in half to make it half in the morning and half at night. You're at 25 units of insulin twice a day, and then cut it in half to err on the side of safety with gestational diabetes, because you're almost certainly not fully replacing somebody's insulin requirement. You end up around 10 to 15 units of insulin for a nighttime dose. And so functionally what I end up doing most of the time is starting people on 10 units of insulin and seeing how it goes at nighttime. I always focus on fasting hyperglycemia, fix the fasting first, because you really can't fix postprandial if you come into the day high. So in terms of prandial hyperglycemia, if you fixed somebody's fastings, but they still have postprandial hyperglycemia, first look at what they're eating. Sometimes people have cut out all sources of carbohydrate that are processed, and they're still finding that vegetables make them hyperglycemic. It's unusual, but it can happen. Or more commonly, people have a lot of trouble modifying diet because it's hard, and sticking to a very low carb diet is not what we're recommending. It's also really challenging. So sometimes people need insulin to be able to eat. And if that's the case, you can start with a rough estimate of 1 unit per 10 grams of carbohydrates. I think it is helpful to teach patients how to read labels and to count their carbs. That may be something where your nutritionist colleagues can help. And I like to give a short-acting insulin, so I really don't ever use regular insulin. I typically use a long-acting insulin for basal, usually NPH because it's cheap. sometimes Detamir, depending on the patient's insurance. There is at least one payer that prefers Detamir to MPH, so it's cheaper for the patient. I don't typically use a 24-hour-long basal like Glargine, but you could if you needed it. And then for mealtime coverage, I usually use Novolog or Humalog, so one of the fast-acting, Lispro, one of the fast-acting insulin analogs. Those have been shown to be safe with pregnancy. None of these cross the placenta, and all of them, the risk of insulin is certainly nothing compared to the risk of not having good glycemic control. So metformin, just to touch on it, metformin basics. Metformin is considered an FDA pregnancy category B medication. What metformin does, it enhances hepatic and peripheral insulin sensitivity. It freely crosses the placenta. So if you're giving a patient metformin, you are also exposing the fetus to metformin. And we'll get into what does that matter in a moment. The initial dose for metformin for folks who haven't used it is 500 milligrams, usually started at once a day up to twice a day. It can be increased up to 2,500 milligrams daily, and typically dosing can be limited in the beginning by GI symptoms, so that's the most common complaint with metformin. Metformin has been looked at in an open-label randomized controlled trial for the treatment of gestational diabetes, and in a study called the MIG trial. Women were randomized to treatment with metformin versus insulin if they failed medical nutrition therapy. And there were a couple of key points from the results of this study. One was that the majority of women required the maximum dose of metformin, up to 2,500 milligrams daily. So almost everyone needed the full dose. Of the metformin group, 50% also required insulin on top of it, so that metformin just simply wasn't enough. In the study, there were no differences in neonatal morbidity or maternal complications. Interestingly, the metformin group gained less weight and lost more weight by 8 weeks postpartum, so maybe there were some maternal metabolic benefits in the metformin group, although one could argue also that maybe their GI symptoms limited, who knows. I think the safety question is the bigger question. So metformin is pretty conclusively, there are several meta-analyses out there and several good case control studies looking at the risk for congenital malformations. And metformin, if anything, may reduce the risk for congenital malformations in the first trimester, almost certainly because of an improved insulin resistance and reduced hyperglycemia. As we know, high glucose is a known teratogen. Metformin probably has some impact on fetal growth. We don't exactly know what the impact is, but given its free placental transfer, there is a lot of concern about the possibility of long-term impact on offspring adiposity. And we have really limited long-term follow-up data. So right now there's a study looking at at the children from the MIG trial. It was published last year, suggesting that the 9-year-olds offspring of the women exposed to metformin were more adipose, had higher BMIs than the group that was not exposed. I think the fact that there was a signal seen, even if it was a little bit hard to interpret, was very concerning to many investigators. So there were a group of diabetes and pregnancy researchers who wrote a position statement in the Gray Journal last year expressing their concerns about the use of metformin in terms of long-term fetal programming. We know that untreated diabetes also has definite long-term fetal programming sequelae. So I think the real question is, if your patient can do insulin, that's ideal. If your patient can't do insulin, what's better, metformin or nothing? Clearly, I think good glycemic control is better than no glycemic control. I do want to talk a little bit about Glyburide, because I think where I feel more conservative is in the use of Glyburide. Glyburide enhances pancreatic secretion. So if metformin is very simply put kind of exercise in pill form and that it makes you more insulin sensitive, Glyburide is like regular insulin in pill form. The timing of action, it kind of enhances your pancreatic insulin secretion somewhere around 4 hours after you take it. It's a little bit hard to titrate sometimes because folks can be limited by hypoglycemia. These are the starting doses and that's the max dose. In vitro, it doesn't cross the placenta, but in vivo, it may cross in small amounts, and more recent data has suggested even as much as 70% crosses the placenta. So it's considered a category C, and I think there are a lot of cautions with using Glyburide. My experience with Glyburide is that if you have fasting hyperglycemia, it's less likely to work. You're just not likely to get there with oral doses. People also really need to eat regularly, much like regular insulin. It hangs out for a long time. So people really need to be eating every 2 to 3 hours, or they will get hypoglycemic, and that will limit their ability to either adhere to it or their safe, it can be a safety concern, obviously. And then, people on Glyburide or Metformin, for that matter, really need to be treated as if they're on insulin. You really need to think of them as people who are insulin dependent diabetes, because you're needing a medication to manage their hyperglycemia. And I think sometimes with Glyburide and Metformin, depending on which one you're using, it can feel like, well, they don't have that bad of GDM, but I think we just need to think of these as like option B to insulin. So Glyburide, there's been one study that showed pretty good results. It was an open label randomized controlled trial published in the New England Journal now almost 20 years ago. Showed similar glycemic control in the Glyburide arm to the insulin arm, and very low crossover rates to insulin. They found no measurable cord blood levels. Other studies have never been able to replicate these results. Specifically, other studies have found that a much higher proportion of patients need insulin. Many more patients complain of hypoglycemia. There are measurable cord blood levels. So I think the rates of maternal hypoglycemia are unclear. That's what that means. But I think the upshot is that Glyburide's not such an easy drug to use. All of that said, Glyburide is among the more commonly used drugs, and actually these are data from commercial claims in the United States. So a huge database of women with gestational diabetes, and they looked at the rate of Glyburide, claims for Glyburide, and what they found was among folks diagnosed with gestational diabetes, nearly 2/3 of them had been prescribed Glyburide by 2011, so it had exceeded the use of insulin by a lot. The same group looked at those claims, and they were able to look at the newborn outcomes, and what they found were that newborns of women who were treated with Glyburide were at increased risk. Again, these are compared to women treated with insulin. So among women with gestational diabetes, if you got Glyburide, your risk was higher for having a baby who needed to be admitted to the NICU, for having respiratory distress, hypoglycemia, birth injury, and large for gestational age. And I think there's two questions. One is, could Glyburide be crossing the placenta, causing fetal hyperinsulinemia, which would cause all of these problems? Or two, is Glyburide just an insufficient treatment for the vast majority of people who then have still persistent hyperglycemia, who have then fetal hyperinsulinemia, who have all of these adverse outcomes? I think either way, it's clear that Glyburide in real world practice is not doing the trick, and so it's not my go-to agent. I think I would consider this really a second line choice. You can use it if you need to, but if you have other options that the patient can take, that's better. I want to touch on delivery planning a little bit. I think that's a really controversial area in gestational diabetes. So as of the most recent ACOG practice bulletins, and it comes up in several, gestational diabetes is not an indication for early delivery if it's well controlled. What that is I think, a little more controversial. Induction should be considered at 39 to 40 weeks for the prevention of stillbirth in patients who are on insulin or other medical treatments. And we should be talking about a cesarean, or at least thinking about a C-section, for anybody with an EFW of greater than 4,500 grams, with all the usual caveats about the management of macrosomia, which is that ultrasound estimates of fetal weight are imprecise at best. And so our methods to assess fetal weight are limited, and therefore we will certainly perform more C-sections than we need to prevent one shoulder dystocia or birth trauma. I think the question of whether gestational diabetes is associated with stillbirth is a little bit open. It probably is. Older data with small numbers of patients for this question have shown very varying degrees of association of stillbirth in gestational diabetes. And the reason I included the number in each of these studies is because just a back of the envelope calculation, if you consider the baseline rate of stillbirth 5 per 1,000 in the United States, to see a 50% increase in the rate of stillbirth, the back of the envelope calculation is that you need over 15,000 patients to see a signal. That's again to see a 50% increase. So if you're talking about subtle increases in the rate of stillbirth, you're talking about potentially even hundreds of thousands of patients. And so you really need large population-based studies to be able to look at rates of stillbirth and whether or not they're associated with diabetes. And the trade-off is that you then have less information about the degree of control and what that diabetes is. So a group out of California did just that. They looked at birth certificate data that was matched to fetal death data. And what they found was first that gestational age was associated with the risk for stillbirth at term among women with gestational diabetes. And again, these are birth certificate data, so ostensibly this is the sickest group of people with gestational diabetes because it didn't make it onto the birth certificate. It wasn't statistically significant after 40 weeks, and that's because the denominator goes down as more and more people deliver. But you can see that at 36 weeks, 37 weeks, 38 weeks, and 39 weeks, there was a statistically significant increased risk for stillbirth in the group in diabetes, gestational diabetes. They then calculated the risk of expectant management. So if you were to stay pregnant, what was your ongoing risk? And that became statistically significantly elevated at 39 weeks, pointing to maybe 39 weeks is when we should be starting to deliver patients. That absolute risk difference, or the number of deaths that was increased in the group that was expectantly managed, became statistically significant again at 39 weeks. And it's a very small number per 10,000 births. You're talking about 6 to 7 additional deaths, but it's real and it's statistically significant and it's there. I think the question of what do you do with that information, they did also calculate the number needed to treat, or the number of patients that you would need to deliver to prevent one stillbirth in gestational diabetes. And if you delivered everybody at 38 weeks when that relationship becomes statistically significant, you'd be delivering over 4,000 women to prevent one stillbirth. At 39 weeks, that number is still 1,500, and then it goes down at 40 weeks. But I think the sweet spot is probably somewhere in here. We should be talking about delivery to reduce perinatal mortality. I think the question is just what kind of resources does that consume, and what does that mean for a system to be talking about delivery of everybody with gestational diabetes. These are just one more study emphasizing that. I included it because it was just published this year, and it was a case-controlled study out of the UK where they were able to separate out people who were treated versus untreated, because they had a group of women who should have been screened and weren't, basically. And in that group of people who should have been screened, were not, or were screened and weren't treated appropriately, what they found is if they had risk factors and never got screened, there was an elevated risk for stillbirth. And if they had risk factors, got screened, but never got treated, there was a significantly increased risk for stillbirth. So the bottom line is that for sure, when we don't treat gestational diabetes, there's an association with stillbirth. And this is, again, just showing very similar to what the HAPO study showed, that when they were able to look at the group of women who had fasting plasma values, the risk for stillbirth was basically linearly associated with maternal fasting plasma glucose. So much like all of those other adverse outcomes, again, a similar relationship to what was seen in the HAPO study, which wasn't specifically looking at perinatal mortality. There are no adequately powered randomized controlled trials of delivery timing or delivery strategies for women with gestational diabetes. And I think I'll just leave this delivery discussion by saying that we need to kind of put gestational diabetes in our minds in the context of what else is going on in our world. So we certainly know that all of us know that there's a big push to end non-indicated early term delivery. The Joint Commission has adopted this as part of its core measure set. The March of Dimes has invested a large amount of money, time, and effort in reducing early elective deliveries. All the state perinatal collaboratives have gone to this, and payers are now including early elective delivery as quality measure for risk contracts. And so we were interested a few years ago in, like, what is this whole 39-week push done to delivery for people who probably need to be delivered in the early term period, or at least we need to be thinking about it. And what we found was that if you looked at all of these were the percentage of term births that occurred prior to 39 weeks. So these are the 37 to 39 weekers. In 2005, 2006, it peaked, and that number started to go down as attention started to get focused on that. But in parallel, we started delivering folks with diabetes later, and we started delivering folks with hypertension later. And by we, I mean the United States. These are birth certificate data from the entire US. So I would just give us a note of caution that while 39 weeks is that sweet spot for stillbirth for kind of uncomplicated gestational diabetes, we just need to be mindful. It's not the worst thing in the world to deliver somebody before 39 weeks if they have a significant indication. So I want to spend the last few minutes talking about best practices for prevention of type 2 diabetes after pregnancy complicated by gestational diabetes. So just to review, as you go out after delivery, women with GDM are very likely to develop gestational or type 2 diabetes. So this is the cumulative incidence of type 2 diabetes, and these are various cohorts and different markers here. But basically, the farther out you follow a cohort of women with gestational diabetes, the higher percentage of them will have gone on to develop type 2 diabetes. And we know we usually quote people a risk of somewhere around 50%. And I mentioned this earlier, but again, these are data from that cost effectiveness analysis that treating gestational diabetes is only cost effective if we prevent diabetes. So if you do the two-step Carpenter-Kustand criteria, you probably you prevent just over 400 women from getting type 2 diabetes per 100,000 women that you screen. If you use the IAD-PSG criteria, you identify many more patients, so you prevent more cases of type 2 diabetes. But if none of this matters, if you don't do anything in terms of long-term maternal health, then you're talking about $500,000 per quality adjusted life year. This rapidly becomes a very, very expensive enterprise that really one could ask, why are we spending all of this money to prevent or to screen and treat gestational diabetes if we're not going to do anything about it afterwards? So both the ADA and ACOG recommend screening in the postpartum period. At the postpartum visit, which is now 4 to 12 weeks, we're all kind of on the same page. One thing I would say is don't use an A1C in that postpartum visit. Use an oral glucose tolerance test or a fasting, and use non-pregnancy diagnostic criteria. And then people should have screening at least every 3 years. If they have abnormal screening at that first test, even if it's under the diagnosis for type 2 diabetes, they should be screened every year. Just underscoring, 1 to 3% of women will have overt diabetes if you screen at that 6 to 12 weeks postpartum after gestational diabetes, but up to 1 in 4 will have an impaired fasting glucose or impaired glucose tolerance. And really importantly, we do know that intervention in that group of folks can reduce the risk of progression to type 2 diabetes. The Diabetes Prevention Program, which I'll show you later, has established that kind of conclusively. So we know that we don't do a great job of screening in the postpartum period. This is just one study of a multitude that have demonstrated that while we see patients in the first year postpartum, so this is a cohort of women of whom nearly all got pap smear in the first year. So nearly all got, and these are old, you know that people were getting annual paps. So within the first year, the vast majority had been seen and had been screened for cervical cancer. However, only about 30% of them had gotten the recommended screening for diabetes, as many as several years after their incident pregnancy, and any sort of any sort of diabetes screening at all, it was still the minority. So we really need to be thoughtful about what we're doing in the postpartum period for screening. We also know that if you look kind of farther out after folks are in theory transitioning to primary care, only about 1/3 are getting ongoing screening. And so several groups are focused right now on how do we get this group of women who might particularly benefit from intervention engaged in care and improve screening rates. Like I said, we do know that intervention prevents progression. So the Diabetes Prevention Program randomized thousands of people to either metformin, a lifestyle intervention, or a placebo, and showed that both metformin and lifestyle intervention decreased the risk of progressing to type 2 diabetes over time. Lifestyle intervention was actually the most effective. That lifestyle intervention was pretty intense, and so a lot of groups, including groups locally, have looked at ways that we could adapt the diabetes prevention program for a postpartum population. I think not quite ready for prime time, but stay tuned. There is definitely hope for an intervention that you could refer your patients to on the horizon. So I'm going to end with that and open it up for questions. I think we have a few minutes. I'm hoping that the technology works so that we can answer them. Let's see. Pause.
Yep, and I was just going to put it on that.
Okay. Okay. Please address early screening in at-risk women, oral glucose testing, hemoglobin A1C, or both. So I got rid of these slides because I didn't want to go over my time, but a couple of things. Early screening for overt diabetes is conclusively recommended. We should be screening anybody with risk factors for diabetes, for type 2 diabetes, at the first prenatal visit. How you screen those folks should be with a test that would be useful for diagnosis of type 2 diabetes. So depending on your gestational age, a hemoglobin A1C might be useful if you think that you're early enough in pregnancy that it's a reliable test. As you get further along in pregnancy, the increase in plasma volume and the increase in red cell turnover is going to make your A1C a little bit less reliable. It's going to drop. But if it's high, it's probably I think it's a very specific test. It's not necessarily particularly sensitive. A fasting is a reasonable test to do as well. If you want to formally screen with a 2-hour glucose tolerance test, that's also a reasonable choice. I think functionally, most people, if they're going to screen at that first prenatal visit, often end up with an A1C. And let's say you have a first trimester A1C that is 5.9, what do you do with that? So we know under 5.7 is normal, over 6.5 or higher is abnormal. What do you do with the vast middle? And there have been a couple of groups that have looked at this. Probably what we recommend as part of our Joslin diabetes and pregnancy program is 5.9 or higher be treated as gestational diabetes. So that pre-diabetes range, 5.9, that's pretty predictive of needing insulin. And other groups have demonstrated that that it's very sensitive for the diagnosis of gestational diabetes, or I'm sorry, specific for the diagnosis of gestational diabetes later in pregnancy. Whether treating gestational diabetes early in pregnancy is beneficial is a very controversial topic right now. That is not totally clear, and there have been a couple of small studies suggesting that there are limited benefits for early treatment of gestational diabetes. So functionally what I do is I get an A1C, I treat people who are 5.9 or higher, and by treatment I mean referral to nutrition, discussion of lifestyle management, and start checking sugars. I think it pretty quickly becomes apparent if people have like really overt fasting hyperglycemia. That's the most common pattern I see. But really you're operating in a guideline-free zone. So I think pick a standard and go with it, and that's the reasonable thing to do. The other big question that's out there right now is, do you do an early GLT in somebody with risk factors? Usually obesity is the one that gets mentioned. And the various guidelines actually conflict. If you look at the ACOG practice bulletin on obesity, the ACOG practice bulletin on gestational diabetes, the ACOG diabetes practice bulletin, the bariatric surgery practice bulletin, there's a bunch of different guidelines that are out there, but functionally, I find it challenging for patients to do multiple two-step testing strategies. So if you do a glucose tolerance test early, you do a 50-gram glucose load and it's abnormal, and then you get a 3-hour glucose test and that's normal, I would not repeat the 50-gram. I do think that it's also problematic when people get screened at 18 weeks or 20 weeks, but then don't get repeat screening if it's positive, if it's negative. So I think you may be too early to catch clinically relevant hyperglycemia. And if you screen people early but then don't rescreen them, it's problematic. So what I recommend is screen for type 2 diabetes in the first trimester and do it with a test that you will then follow up if it has a middle ground. So either with a 2-hour glucose tolerance test, because you can find impaired fasting or impaired glucose tolerance test, or with an A1C, because you can find a prediabetes range A1C, and then leave them alone until the 3rd trimester and screen everybody else who doesn't have overt diabetes or prediabetes in that 3rd trimester. I don't like the early 50 gram, and I don't think there are enough data out there. There was a study published or presented last year at SMFM suggesting that maybe it was associated with harm, so I'm not a fan. Okay, I'm going down.
You just look right there.
Hold on, I think that's all the same question.
Yeah, that's it.
Okay, any other questions out there? All right, well, it's 6:01, so I think we'll end there. I'm gonna I wanna unpause my screen 1 second. How do I do that? Big play button, just so I can put my email address up there. Feel free to email me, follow us on Twitter. And the next webinar is going to be talking about the ARRIVE trial or implications for the elective induction of labor after 39 weeks. We'll get back to you with a date soon. Thank you for joining us. Like I said, please feel free to reach out to me with any questions. I'd be happy to answer.